What's the ideal way to make good healthcare choices? Put another way, if you or I needed medical care, how would we want to be treated? Let's imagine I crash while skiing, a realistic prospect, and I rupture my ACL. We can picture my recovery as a journey. My voyage begins with knee pain and instability. My ideal destination is normal function, unlimited exercise and no pain. How do we identify the fastest, safest and most comfortable way to get there? The ideal guide should be my GP. In this analogy, they'll always point me towards a professional driver. In human healthcare, this means an orthopedic consultant. Let's imagine I get lucky. I'm assigned the best driver in the world. Should I worry about when or where he passed his driving test, or how many times he's driven a car? Should I ask what car he drives? I don't need to worry about any of these things. They don't matter because I can check my driver's ability online. I can check his success rate, i.e. how many times he's won, and I can find out his complication rate, i.e. how many times he's crashed. Knowing my driver's stats leaves me free to focus on my role in this journey. Thank you, Mike. That was our ideal scenario. Now let's take a look at a real-world scenario. This time our journey begins with a painful pet. A carer asks directions from their GP, but what happens next is less predictable. Some GPs direct carers to Formula One drivers and some don't. In our analogy, GPs who don't make a referral are driving enthusiasts. They have a driving licence, driving experience, and they even drive the same car as a world champion. So, is it fair for an experienced driver to quote a world champion's driving statistics? If the answer's no, is it any surprise that carers ask questions they shouldn't need to ask? For instance, is TPLO better than TTA? To me, this is like asking if a Ferrari is better than a Tesla. Online misinformation exists because the entire system is unpredictable. This analogy is of course an oversimplification. What really happens is this. A surgeon climbs into the metaphorical driving seat and a pet owner takes the passenger seat. Off they go, then a mile up the road they pull over so driver and passenger can switch seats. The driver gives the co-driver a 10-minute lesson. There's the gas, there's the brakes, here's your instruction manual, try not to crash. So who's to blame if they do crash? Is it the car? Did our driver make a terrible mistake when he or she chose a Ferrari? According to the internet, they should be driving a Tesla. They hardly ever crash. So it must have been the car. Self-serving bias means our human instincts compel us to blame others. It couldn't have been my fault, so it must have been their fault. This is how self-serving bias looks in our analogy. Our driver, an orthopedic surgeon, doesn't believe they're at fault. I didn't crash the car. I gave excellent instructions. It's not my fault if my co-driver didn't follow them. The carer is equally reluctant to accept blame. From their perspective, there must have been something wrong with the car, or the owner manual, or the driving lesson. The big question with our crash scenario isn't how should we pick up the pieces. The big question is, can we find a better way to avoid crashes? To answer this question, we need to help our co-driver. This means we need answers to two other questions. Question 1, are veterinary discharge instructions too complex? And question 2, do pet owners read them? Thanks, Mike. The University of Michigan conducts regular scientific surveys. Their Civic Scientific Literacy Survey tests the public's ability to make sense of a newspaper story. The chosen story is the New York Times Tuesday Science article. Here's an example article which explains the genetic relationship between dogs and wolves. The most recent survey, performed in 2016, found that 7 out of 10 people misunderstood the chosen article. So, did the New York Times misjudge their audience? Probably not. Readability software shows New York Times science articles are consistently easy to read. This article has short sentences, few complex words, and a readability score of 75 out of 100. So what happens if we run a surgical discharge instruction through the same software? Here's my TPLO discharge instruction, which I used for nearly a decade. Compared to the New York Times article, It contains 20% more complex words, the sentences are twice as long, and it's 20% less readable. I thought my discharge instructions were simple, but what I thought doesn't matter. What matters is that my instructions were too complex for the people reading them. Question 2. Do people read terms and conditions? University of Connecticut researchers asked this question in a landmark study. They created a fake social networking site. They invited users to read a typical online terms and conditions document with a twist. Clicking accept meant users agreed to give up their firstborn child as payment and consented to sharing all their data with the NSA. A whopping 98% clicked accept. Consent forms and discharge instructions are terms and conditions documents. Could they be subject to the same effect? Hundreds of clinical studies asked this question. Some produced breathtaking results. For example, only 1% of people spent over 5 seconds reading a surgical consent form before signing it. Only 8% of parents read discharge instructions describing safe aftercare for their child. 27% of patients didn't know which organ they'd had operated 2 to 5 days after abdominal surgery. I'm not the first to ask if there's a problem with the format we use to convey important information. Many studies show improved understanding when doctors provide multimedia instructions. Improved understanding means less anxiety and lower risk. So, what do multimedia guides look like? Here's a quick tour of some free access examples on the VetLessons website. Thanks, Mike. We begin by addressing fear of the unknown. It's one of the main reasons pet owners are often anxious about leaving a loved one in hospital. I built our homepage with this in mind. We take carers behind the scenes in a specialist hospital using a series of time-lapse videos. This example shows a 30-second time-lapse of a patient undergoing triage. The cruciate ligament injury page uses a similar format. It includes a time-lapse journey through a TPLO operation. The next stop on our tour is our chronic pain and lameness resource. These pages use narrated videos to teach carers the signs of chronic pain in dogs and cats. There's a free online version of the Helsinki Chronic Pain Index and links to other pain metrics. I've included a feline chronic pain tool which we calibrated using data from over 1,000 pain-free cats. For owners interested in genetic joint diseases, I've included breed statistics pages. The next stop on our tour is the cruciate ligament injury page. This page contains a family of plain English decision aids. Each decision aid is a literature review with a difference. I've used readability software and visual aids to make complex data more accessible. For instance, these videos have equivalent readability scores to a New York Times Science article. Readability isn't the only important metric. Lack of bias is also key. I'm lucky in this respect because I'm not burdened by a conflict of interest. VetLessons is non-profit. I'm not trying to sell anything. To bring us full circle, we finish with the surgical driving instructions. These are the tools we use to train our co-drivers, the all-important pet owners. They're also the guides which make the most difference to my daily life. Each surgical aftercare guide describes an orthopedic operation. Every guide answers owner questions about safe aftercare. Carers learn what an operation is and what sort of recovery to expect. All guides include advice about safe exercise, pain control and troubleshooting. If you like the idea of a free access resource, you know what to do next. Share and subscribe.